Okay, welcome to this next panel that we've called a jumbled mess of things: neurostorms, movement disorder, and behavior. I'll talk about why we've included all of that, but what I think we're mostly talking about here is something called PSH that's been known about for a while as something that happens to people when they hit their head or when they are not able to breathe for a while and maybe have partial drowning. And so Dr. Keith Coffman, who's here, is sort of leading the charge at showing that there's also a genetic basis for this PSH. Michelle Lewis is a parent from another rare disease. Her daughter has SCN2A, and she's also on the family's SCN2A Foundation. She's a director there. And I'm also going to talk about my son, Bryson. And I think that Michelle was sort of the patient zero as Dr. Coffman was discovering some of this, or at least one of the early patients. So we have this kind of jumbled term because this is something that came up when we did a family survey just over a year ago. And in addition to asking all of our families what symptoms their children had, we asked them to take those symptoms and then identify, if we could work with researchers to find cures or treatments for only one of all of the symptoms your children have, what would you pick? And so then we kind of grouped some of them together based on focus groups that we had after. And so, not surprisingly, the top two were intellectual disability and communication, followed by epilepsy. But then there was this other category of mood, behavior, and neurostorms. And when we did focus groups with the families, we really found that there was a lot of overlap in this category, and that people were, when they heard others talking about what they had, many people were describing sort of the same thing. So we were grateful actually to learn about Dr. Coffman's work through Leah, who also works at SCN2A with Michelle, and we're excited to be in contact with him. I also just wanted to mention, this is something that I haven't shared with Dr. Coffman before, but in the phenotype data for GRIN1 in the patient registry, they've noticed that 61% of GRIN1 patients, or parents of GRIN1 patients, report that their children have movement disorder. And of those, 22% report something called oculogyric crisis, which is a type of movement disorder. The main presentation, I guess, is it almost looks like the eyes are rolling back in the head. I think sometimes it's accompanied by a grimace and some other things. But I just pulled something out here, and this is just from Wikipedia, so I may be insulting some researchers on the call by citing Wikipedia. But it says here that some of the things that can also happen during the attacks are pupil dilation, increased blood pressure, heart rate, facial flooding. So some of the things that we think of as associated with PSH. So I don't know if there's a connection or not, but I thought I would mention that. There was also in the presentation this morning from there was a presentation from a GRIA2 mom who's both her husband and daughter have GRIA2 disorder. And her husband, when he was younger, had the same oculogyric crisis. So we know so far that it exists in GRIN1, maybe also in this other oculogyric crisis. And the one other thing just to mention is that, also heard today from a GRIN1 family in her presentation, and she was talking about autonomic respiratory conditions. And basically her child throughout the day, in addition to having some of these things that we see in PSH, throughout the day, her child goes through these cycles of not being able to breathe, for multiple, like a long time, turns blue and then breathes again, and it's kind of continuous through. I think it doesn't happen when the child's asleep, but when the child's awake, it happens sort of continuously. So that's pretty frightening and pretty extreme. So obviously at CureGRIN, if it's a focus for our families, it's something that we also really want to focus about, and especially because this is something that is not well understood, among the patient population, but more importantly among other researchers and clinicians. And I think that just talking for my family, this is my son Bryson. And most of the time, this is what he looks like. He's a super happy, social, loving guy. You can see he's got COVID hair there. But he also has these episodes where he gets, sometimes can get extremely violent. We've always wondered what they were. Are they we spent a lot of time with doctors wondering if they're seizures. He had multiple EEGs to try and detect seizures. The doctors weren't able to see anything on an EEG. Then one doctor saw an episode, thought it looked like a seizure, so Bryson's been treated for that. We really spent, he's 15 now. We spent 15 years trying to figure out if they were seizures. And more recently, actually, even just before we talked to Dr. Coffman, there was a research or a neurologist in Toronto who put Bryson on NAC, and which is actually a supplement that helps with oxidation, and gabapentin, and we noticed that these drugs seem to be helping with the storms. More recently, he's been on clonidine, which is helping even more. I think his dose still isn't big enough, but we definitely noticed that it's helping. But just to just talk a minute about kind of what it looks like. Bryson, lately it's sort of more predictable what the pattern looks like, but he'll often start by kind of tightening up and twisting. We can see him kind of twisting his legs, like it's clear that he's uncomfortable. He sometimes starts kind of making a scream or a wail or a grunting sound. And then it can become quite violent for a while, with him kind of thrashing around. Looks like he's in a lot of pain. We see his pupils increase. We notice his heart rate increasing, and then it just stops. It suddenly, it can go on for 20 minutes, and then it suddenly stops. And I think that, for us, two of the things that to look for that in retrospect were important were, one, the enlarged pupils that suggested that there was something autonomic going on, not a seizure, and also just the way that it suddenly stops, and there wasn't really an ictal phase afterwards, like people with seizures see. So I'm just going to show a short video. This is a 20-minute episode that we've cut down to about 2 minutes of Bryson experiencing one of these. Yeah, so there are a lot of tough things about being the parent of Bryson. Like, his life is really hard. It's hard to be a caregiver, but this is definitely the hardest thing that we have to deal with him. And I mentioned at the start that it can be violent. There have been periods where it's just impossible to get him to stop biting himself when he's in the middle of one of these. We've been, when he's biting his wrist, we've been worried that he would tear an artery or something. So it is definitely frightening. When we're out, it is a real challenge. There was a time that he was happy and calm, and we were at the beach. My wife was kind of carrying him over some rocks, and one of these started, and she was just like worried about, I don't know, if she had to do like an impossible task on it by herself to get him to safety. So yeah, so I know that many other families go through this as well, and looking forward to hearing about Michelle's family situation.
All right. So as Keith mentioned, my name is Michelle Lewis. I reside in Kansas City, Missouri with my family. This is my beautiful 8-year-old daughter, Eliana Lewis, who is probably a pretty good, pretty classic case of PSH. And I would say probably arguably, without total knowledge, probably a pretty severe case of PSH. So what I'd like to do today, and I can answer any questions later, I didn't put videos in, but if anybody would like to see videos of after I get done talking about what Ellie's storms look like, I'm happy to share those. If people, they can feel free to email me. I can put my email in the chat when I get finished, and I'm happy to email videos if people want to see what her storms look like. So, okay. So just a little bit here. This is kind of our diagnostic timeline. So Ellie was born in 2013, New Year's Eve. Right after birth, we were transferred to the NICU at Children's Mercy here in Kansas City. And we remained inpatient through May of 2014. So just right at about 5 months, we were in the NICU. Most of that had to do with what we know now as our genetic diagnosis of SCN2A, which is a sodium channel genetic mutation. So once we were released from the hospital, a few months later, so at this point it's June-ish 2014, this is where we started to see a little bit different symptoms. We were used to seizures every day, daily seizures. We still have daily seizures. That's just kind of our reality now. And for the first part of our life, that was the most important thing, was seizures. But once we started to get towards the end of our first year, that's when we started to see these other symptoms that started to creep in. And we had to go through a long process of ruling a lot of things out, because you don't know what they are. They can't tell you. So you just kind of got to figure it out and play detective. So in around July of 2014, Ellie started waking up in the morning, and shortly after waking up, she would, I just say inconsolably crying, because she would just cry. We weren't sure what was happening. We weren't sure what was going on. The cry was very, very neurological. It seemed, it was what we call a neuro cry. It was very regimented and it wasn't a cry like I'm upset because somebody took my toy cry, that has inflection and things like that. It was very straightforward neuro crying. So we immediately went in for EEG. We ruled out seizures at that point. So the question was, what is it? At that point, early on, we were considering things like central visceral pain, things that we couldn't quite put a finger on, but might be happening. So we tried gabapentin, which we are still on today. And we tried a very low dose of clonidine at that time. It didn't seem to help any. By the time we get to March of the following year, so at this point, she's 14, 15, 16 months old. The crying had worsened to sometimes as long as 8 hours a day. I know, Keith, you had mentioned your son, he has these spells and then he's done. For Ellie, it came to the point where it's like she couldn't turn off. She was crying and crying and crying. And then we started to see all these other symptoms that were starting to emerge along with the crying. And it's like she would get upset and frustrated about something and then just couldn't turn off. So this is where we start to see the dystonic posturing. For Eliana, that was a stiffening of her legs, specifically her right leg would stiffen to the point that she was actually subluxing, or putting her hip out of, her hip was out of joint because of the tightness and the stiffness of the leg. She started to develop tremors in her upper extremities, which we still deal with to a certain extent. But it's just a shaking. It's very like somebody that has Parkinson's is similar to what it looks like, with her shaking in her upper arms. At this point, we're continuing to look for questions, trying to rule things out. So we thought maybe it's GI. We have a lot of GI issues within our community. So maybe it's reflux or GERD. So we ruled that out. that wasn't it. So we know it's not seizures, and we know it's not GI related. We tried with the dystonia starting to become an issue. We trialed a few different things. We trialed low dose clonazepam. It didn't really work at the time. We trialed Benadryl. I'd read some articles, and our neurologist at the time was like, sure, we can try it. Ellie unfortunately had a completely opposite reaction to what we wanted. So we quickly took her off of that. But over the time, so really from talking about the early spring of 2015 to May of 2015, that's where we really kind of had our breaking point. Our family, we call these months like the dark days, because it was a lot of crying, and no, we didn't have any answers. So the crying continued. By May of 2015, there were days where Ellie was crying inconsolably up to 16 hours a day. And we couldn't, there was nothing that we could do to stop it. This is where we started to see an increase in what we now know it's cyclic vomiting. So she would have episodes where she would throw up, which was not uncommon with Ellie and with other members of our community. But the problem is she would throw up, and then she'd throw up again, and she'd throw up again. And we'd have, she would go 24 hours, and anything you tried to put in her, meds, water, food, anything, was coming straight back up. And then she would be fine for, 2-3 weeks, nothing. And then it would happen again. And so we saw this cycle happening. We continued to have the dystonia and the tremor that were continuing to be an issue. During one of her storms, so she'd been crying most of the night, and I'm a teacher and I have to get up early in the morning. So my husband, who is a saint, was staying up late with Ellie, and he had her up on his chest just trying to console her, but we couldn't. And she had her stiff legs like she always does, and her tremors in her arms. And all of a sudden, he said, he came and woke me up in a panic, and he's like, her crying, it changed. Something changed with her crying, and something's wrong with her leg, and it was limp. She had actually, the dystonia and the tremors had gotten so bad that she actually fractured her right femur. So we immediately took her to the emergency room while inpatient for the fractured femur and for pain management for that. That's where we met Dr. Coffman. And he looked her over and kind of, after some thinking, came back and said, she kind of looks like she has PAID, which is paroxysmal autonomic instability with dystonia, which he said was common with people that have like traumatic brain injury. But nothing in the literature about kids like ours having that. So we're like, okay. And so we were released and went home, thought we had a good plan. And then were admitted back shortly after that because these events were happening again. She was going into status dystonicus, and we didn't have a way to stop it. So at that point, that kind of, once we were on Dr. Coffman's service, it took us, I would say, a good 1.5 years, almost 2 years, to come up with the best meds to work for her. And to get her to a place where she's at now, where she's a 99% of the time is a happy, smiley kid. And we occasionally have breakthroughs. We occasionally have some cyclic vomiting, and we occasionally have some of these sympathetic storm breakthroughs, but we treat them with rescue meds, Valtoco, which is the nasal diazepam for the storms, and then Zofran for the cyclic vomiting. And those things, they work. And they've helped to reduce storms and prevent her from going into that sympathetic cycle that she just can't get out of. So that's a little bit of our journey. I just wanted to put this out there so people could see it and kind of have an idea of what we're dealing with here. I just put kind of some of the things for Ellie, some of the symptoms that we see that we had to kind of piece together, because they were all these different things that we had to look at and say, well, what is all of this? And I don't know if Dr. Coffman will talk about it, but I love how he talks about, treating the whole patient. And it's not just treating, the neurological issues, but it's treating the whole patient and looking at the whole picture. So things we see with Ellie: increased blood pressure, heart rate, breathing, sweating, dilated pupils, the dysonic posturing for her, an upper extremity tremor. We see the redness, the skin flushing. Every once in a while, we see a shiver. Most of the time, it's in her chin. And then obviously, if it's left untreated, that's when we see the crying and the agitation. Some triggers for Ellie include GI and urinary discomfort that we see with a lot of our kids that with neurological issues struggle with those. Overstimulation. She loves to participate with school and things, but if she gets overexcited, anything, even if it's good excitement, it can still trigger her and kick her into an episode. Any extreme temperature changes, hot to cold, cold to hot, and then any type of pain response. Those are kind of some of the triggers that we've figured out are things that we have to kind of work around and look for Ellie. On the right, I put the medications that she is currently on. I included the whole regimen here, but because there isn't a single treatment for all of this, it's kind of, we treat symptoms. The clonidine, I mentioned earlier that, early on, we were on a very small dose of clonidine. And, when we started on Dr. Coffman's service, I said, I don't think it's working. And he said, I just think we need to increase it. And so we bumped it up, and it's probably been, I would argue, probably the most effective medication for her. She's on a pretty big dose of it. And the Sentiment, that's carbidopa-levodopa, which is for the tremor. Clonazepam and baclofen, same thing for the dystonia. Bethanechol is something that our GI, that we've gotten through GI to help with, try to prevent some of the GI and urinary discomfort. It helps just to stimulate the bowel and the bladder, which has been beneficial. And the other things are kind of common things that, we see, like non-allergic rhinitis or vasomotor rhinitis for Ellie, which I've incidentally looked into, and that actually can be connected to autonomic dysfunction apparently as well. So you have all these things that we think are these individual things, but in reality, it's really all, for Ellie at least, is tied back to autonomic dysfunction. So, all right, that's it. If anybody has questions for me later, please put them in the chat, or happy to answer.
Thank you, Michelle. That was really interesting, and I think the fact that it just sounded so bad for you guys, and that it could get treated for Ellie, that just provides so much hope, I think, to me and probably to so many other families as well. So we'll take questions at the end. So everyone listening, if you have questions, put them in the chat. Sometimes you can't see the Zoom chat unless your window takes up the full screen. So if you can't see the chat button, just maximize your window. And I'll introduce Dr. Coffman. So he gave a talk about 2 months ago to the Greek community. And within 2 weeks of us putting it up, it already had over 300 views. So it was like definitely I think the most popular video that we've had. There's just so much interest from our families in this, and so little information out there about it. So we're grateful that he agreed to come again today and talk about this. So thank you, Dr. Coffman, over to you.
Okay, so I'm going to share my screen. Okay. Go. All right, so slides look good on your guys' end?
Yes.
Okay, so we're going to go through what I call dysautonomia 101. So a large focus of the talk will be on PSH and excessive autonomic output, but we're going to talk about the entire autonomic nervous system to help everybody understand sort of what it is, what it affects, and the multiple different ways that it can be dysfunctional. Okay. There we go. Okay. So the autonomic nervous system is responsible for the automatic functions of the body. Okay. So as you saw and have heard, this is a top of the head to bottom of the body part of the nervous system. Heart rate, respiratory rate, temperature, gut motility, so moving things from the stomach all the way down through the lower intestine, bowel and bladder control, sweating, fight or flight response, arousal, so your level of alertness, sleep-wake cycles, and sexual arousal as well. Okay. This is a diagram, a cartoon of the entire autonomic nervous system. So you can see from the eyes, mostly the pupil, all the way down to the bladder. There's not a part of the body that is not affected and or innervated by the autonomic nervous system. So there are three technical branches of the autonomic nervous system. So the first is the intrinsic enteric nervous system. So the gut has its own nervous system. And there are, interestingly, more neurons in the gut than in the entire spinal cord. So anytime you think about problems with gastrointestinal motility in children with neurodevelopmental disorders, neurogenetic disorders, this is why. And the gut is densely interconnected with the brain in a two-way street. Gut sends signals to brain, brain sends signals to gut. There's the sympathetic nervous system. So PSH stands for paroxysmal sympathetic hyperactivity, which I said will be the focus. So what happens with the sympathetic nervous system is this is the fast-acting part of the autonomic nervous system that excites the body. Its counterpart is the parasympathetic nervous system. So this is the slow-acting, predominantly inhibitory. So when we think about the classic things we're taught in medical school as physicians, sympathetic is fight or flight, parasympathetic is rest and digest, right? So that's the way that physicians are taught to think about the autonomic nervous system. So when we think about the autonomic nervous system, one of the biggest pieces and why children with neurogenetic disorders have autonomic dysfunction is that there is a part of the brain called the hypothalamus, which lives deep in the center of the brain, and it is the command central for autonomic control. So hunger, thirst, circadian rhythm, so sleep-wake cycles. I was looking on Keith's first slide that sleep disorders are also a big concern in your community, as are respiratory issues, and both of those are part of the autonomic nervous system as well. As you heard Michelle mention about temperature and temperature sensitivity are a big part of the autonomic nervous system, and then everything else, heart rate, blood pressure, sweating, nasal drainage are all affected. So then you get down into the middle of the brain, and in the middle of the brain is where the business end of the central part of the autonomic nervous system is. So you have structures called the raphe nuclei that are cell bodies for serotonin. So serotonin is the neurotransmitter we think of most as it regards to sleep-wake cycles. We also think of the most in terms of mood, and lastly, pain. And the substantia nigra, which is where the cell bodies for dopamine live. So dopamine is the neurotransmitter for alertness, attention focus, and motor control. So if you don't have enough dopamine, you don't move very much at all. Parkinson's disease is characterized by the loss of the dopamine-containing neurons within the substantia nigra. If you have too much dopamine output, you can have involuntary hyperkinetic movements where you move too much. And then the sympathetic trunk, which goes down the side of the spinal column and innervates all of those internal organs. So the first type of dysautonomia we're going to talk about, or we're going to talk about the two overall categories. So hot, wet, agitated, irritable, and stiff, as you saw from Keith's video and Michelle's description. And that's really where PSH or paroxysmal sympathetic hyperactivity comes to be. And then the opposite are patients who are cold, dry, sleepy, and floppy. So this is what happens when you have insufficient autonomic output. So Keith mentioned earlier the young individual who has a problem with what we'd call apnea, right? So problems with initiating breathing. When you don't have enough autonomic output, you can have problems where you have pauses in your respiratory function. Most patients typically only have one type, but this is not an absolute. I currently manage a couple patients who fluctuate between too much autonomic activity and not enough autonomic activity, but those are typically rather rare individuals. So when you think about the first, so insufficient autonomic activity, just so you're all aware of what that looks like, even though that's not the main focus. So really profound sedation. So not being able to wake up much at all, with low body temperature or hypothermia, pallor, meaning pale, cool extremities, low blood pressure, urinary retention, constipation. And the key thing to separate insufficient autonomic output for something like an infection that's causing what we call sepsis, which is overwhelming infection, is patients with insufficient autonomic output have all of these symptoms and a low heart rate or bradycardia. Typically in patients who have all of these symptoms and fast heart rate, that's when you worry about infection. Okay. Typically, these patients are further along in their disease course if their condition is degenerative and they simply can't mount enough autonomic output to sustain body function anymore. Okay. And they may be what's called TPN dependent. So they may have such diffuse dysmotility of their gut that they can't process any food at all, and all of their nutrition is being delivered IV. Whenever I see individuals who have this history, neurology is all about history. If you don't know what a patient has as a neurologist, by the time you're done taking their history, you need more history. You only use tests to confirm what your history and exam have told you. So you can have rare seizure types where you get decreased autonomic output as a result of them. So we often do EEGs to ensure that the patient is in what's called non-convulsive status epilepticus. And, you know, the MRI or CT, I used to say always, but now I say typically, in patients who have autonomic dysfunction may have a very wide, what we call third ventricle, which is one of the natural fluid spaces in the brain, and be due to loss of volume in the hypothalamus. I say typically because I now have a number of patients who have significant autonomic dysfunction whose brain MRIs do not show any loss of volume in this region. So whenever I encounter a patient with insufficient autonomic output, what I do is I look to see what are they not producing enough of. So you can actually very accurately and exquisitely assess neurotransmitter levels in spinal fluid of patients. And that evaluation is absolutely critical if you have someone who has insufficient autonomic output. So we look for what's called homovanillic acid, which is a metabolite of dopamine. And if patients are low in that, treating them with medications to increase dopamine activity is very effective. If the patients are low in what's called 5-hydroxyindoleacetic acid, that's a serotonin metabolite, and adding medications to improve serotonin production can be very effective. And then if they have low levels of what's called 5-methyltetrahydrofolate or 5-MTHF, those patients can typically improve by supplementing them with folinic acid, which is the metabolically active form of folic acid. You cannot use folic acid to treat these patients because folic acid does not cross the blood-brain barrier. You either need to use folinic acid or a methylated form of folate in order for it to get through the blood-brain barrier. Okay. Okay, so Michelle mentioned Cinemet. Michelle's daughter is not on Cinemet because she has low CSF dopamine. She's on Cinemet because she has dystonia. So Cinemet's one of those quirky drugs that can be used even to treat dystonia, even if you have normal CSF dopamine levels. The downsides of Cinemet are that it is a 2 to 3 minimum times a day dosing. You can develop insomnia because dopamine wakes you up. And because there are tons of dopamine neurons in the gut, you can get diarrhea from it as well. Amantadine is one of the other agents we use quite significantly to improve dopamine activity. This actually causes increased release of dopamine, and also it prevents reuptake of dopamine in the synapse. So it helps dopamine hang around more in the synapse. And then if serotonin levels are low, our go-to typically are SSRI, so selective serotonin reuptake inhibitors. There aren't really medications that help you make more serotonin that have been proven to be effective beyond a shadow of a doubt. If you have problems with maintenance of heart rate and blood pressure, your heart rate is too low, your blood pressure is too low, you can treat what's called orthostatic hypertension or hypotension, excuse me, or autonomic failure by using Florinef, which is fludrocortisone. And this is a steroid hormone that helps your body retain more salt and water to naturally improve your heart rate and blood pressure. Oftentimes in my patient population, that doesn't work. So I use more potent medications such as methylphenidate, which is known by many names, Ritalin, Concerta, and others in different countries. The side effects of psychostimulants are exactly what you want in patients with autonomic failure. You want increased heart rate and blood pressure. So we use psychostimulants to treat patients with autonomic failure or insufficient autonomic output because we want the side effects. And then in the US, we have a medication called midodrine. So midodrine works on the alpha-1 receptors to increase their activity. It's so strong and so potent that it actually has in the United States what's called a black box warning. So people who take this medication when they're laying flat can actually develop really significant high blood pressure because of how potent this medication is in increasing heart rate and blood pressure. The downside of midodrine is typically it needs to be given about 4 times a day for sustained benefit. And then in the US, one agent that can be used is atomoxetine. So this is what's known in the US as Strattera. It is unfortunately only able to be taken by patients who can swallow the capsule whole because the actual powder of the medication itself is quite irritating to the gastrointestinal tract. So if you cannot swallow capsules whole, it's not an agent that can be used, unfortunately. And many of my patients are not able to do so, so I rarely use this medication to treat this problem. Okay, so we're then going to start in the movement disorder piece of this and talk about dystonia. So as you heard about from Michelle, dystonia is a terribly painful, involuntary, what we call hyperkinetic movement disorder. So what happens at the muscle level in dystonia is you get simultaneous contraction of both the agonist muscles and antagonist muscles. So the opposing muscles around a joint sufficient to induce a posture. So patients with dystonia will either look locked or frozen or twisted. And because of the mechanism of what's going on from a muscle standpoint, this is exquisitely painful. Dystonia left untreated over time can damage joints, destroy joints, cause increased disability, all the D words that you don't want to hear as a patient or family member or physician. Dystonia is the 3rd most common movement disorder on planet Earth, but it's one that, as you heard Michelle's story, often goes very, very unrecognized by physicians who don't take care of patients with movement disorders like I do. Okay, what's interesting about dystonia, critically important to know from a dystonia standpoint, is dystonia can cause severe constipation, reflux, and I forgot to add urinary retention. So relaxing your sphincters to evacuate your bowels is a voluntary process. If you have really significant involuntary contractions of your abdominal muscles and your paraspinal muscles down your back, you can't relax your sphincter sufficient to evacuate your bowels. Same thing to relax your urinary sphincter. That's a voluntary thing. So if you are too stiff, you'll end up with urinary retention, constipation from dystonia. The opposite is why you get reflux. So what happens that causes reflux is if you have sufficient dystonia around the chest, you end up having reduction in the negative pressure in the chest that keeps the food in your stomach, and food comes up into your esophagus out of your stomach. So all of these things can be a byproduct of dystonia. So dystonia with dysautonomia, as Michelle said, historically was referred to as paroxysmal autonomic instability with dystonia. We now call this, as you've heard, paroxysmal sympathetic hyperactivity, which is a much more anatomically and physiologically accurate term. So what happens in PSH is historically, as you heard from both Keith and Michelle, typically brain disease, so near drowning, brain injury, brain tumors. We now know increasingly that this can occur in patients with neurogenetic brain diseases. Historically, this was referred to as thalamic storms. We now know, based on anatomy and physiology, that these are of hypothalamic origin. So you heard Keith mention, and one of the key things whenever we talk about PSH is timing. So remember, the hypothalamus has the circadian rhythm generator. It's your internal clock. So most people who have PSH, they will have it pretty consistently around the same time every day, because that's when their circadian rhythm causes it to fire. Okay.
Dr. Coffman, I just want to jump in for a second and let you know that we don't have flexibility on the timing this ends because it's set up in the system. It's going to cut us off in 3 minutes.
3 minutes. Oh,
3
my
minutes.
goodness. Okay. So, okay. So when you treat PSH, you have to prevent it. You can't abort it. We use, as Michelle said, everything: controlling room temperature, lower stimulation, regulate sleep-wake, evaluate for pain, and then treatment-wise, alpha-2 agonists in the US, so clonidine, tizanidine, beta blockers, as long as there's no significant asthma, baclofen, as you heard, and then gabapentin, which you heard from Keith. And that is the shortened version of it.
Wow. That was, okay, so then we have a minute or two for questions. I'm just looking back now. So one question: do patients move from the hot, wet autonomic dysfunction to the cold, slow, or vice versa as a disorder develops?
So they can. I have one patient, as I mentioned earlier, who has both. His condition is worsening over time, and as his condition is worsening, he does not have any of the GRIN or GRIA or SCN2A. He has a completely different condition. But as his condition is progressing over time, we're seeing more slow hypothermic days and less hot hyperactive days, unfortunately.
And there's a question maybe for Michelle. How have you found balancing the medication that you've used with how they've made them, your children, not themselves?
Sure. So quality of life is super important to us, and we want to make sure Ellie has the best quality of life possible. So we balance a lot, but in reality, if she's in pain all the time and she's crying all the time, that's a no-go for us. So it's finding the right medications that work, and we've tried lots that haven't worked for us. So I think it's just about finding that balance between your kid and what's best for them and their quality of life, ultimately.
Thank you. Well, so I'll just take a moment, because we might disappear in a minute, to thank Dr. Coffman and Michelle. Thank you very much for joining us. And I'll just say for Bryson, on clonidine and gabapentin, I think both of those have side effects of drowsiness. And so when we started ramping Bryson up on the meds, he was much more sleepy, but that has gone away. So after a while on the meds, he seems kind of back to his normal sleep-wake cycle. We can keep going as long as it doesn't cut us off, because do we have another question?
Keith, it's going to cut you off. I'm sorry.
Okay. Thanks, everyone.
Thanks, everyone. Bye.
Bye.